and ITs. Welcome, everyone. I'm Charlotte Marchandise from EUPHA, European Public Health Association, and I'm really happy to welcome you today for this webinar. It will be recorded. We have 270 people registered online, and we have many good speakers from all over the world. And we also would like to share that this webinar is not just a moment, it's a movement. We are planning to work for a very long time together and not only share with you the science of health in all, health for all policy, but also the implementation, how it goes, what are the good tricks, what doesn't work also. We don't want to say that we know everything. I will do a quick presentation to tell you what is EUPHA and then pass it to the other participants. But before, we would like to know how much you know about public health, about health in all policies. So we'll launch a quiz so you can answer some questions and see how much you know. There you are. So please feel free to answer while I'll begin my presentation, and then I'll introduce the next panelist. And yes, so opposite of what I say, you need, yes, okay, I need to present. So for you to know who we are inviting, on my side, we represent the European Public Health Association, and our strategy is evidence, equity, engagement, and empowerment. To say that, once we say that, we are the umbrella organization of Public Health Association in the WHO European region. For those who are not familiar to European WHO, Europe, and EU region, mostly it's the Europe of Eurovision or football, whatever you prefer. We have 85 members in 47 countries. Most of our members are national public health associations, and our work is to empower them so they know what's happening in Brussels, in Copenhagen, where we have a WHO, in the world, and also to gather scientists in different topics to get the best science, the best cutting edge evidence, and share it to politicians. We also have these networks, EUPHA Next, of 4,000 young professionals helping each other both with peer-to-peer work and also infiltrating all our scientific work so that we do nothing without the young people. We build capacity and knowledge for public health and equity, and we share tailored evidence with policymakers and citizens. We have a scientific journal, European Journal of Public Health. We do this webinar. We have the EPH conference. Next one will be in Helsinki, and the next after will be in Bilbao in Spain. And of course, what we want to do is really to see how science is not only about sharing it between the happy few that understand epidemiology, it's also how do we get it to change the decision making? How do we get it to the general public? How do we get it to communities? And this is something that is often a challenge. How do we connect to community healthcare workers? We've been empowering them for a long time, but we need more help for that. We work with WHO, of course, we work with partner network, and I'll give the floor in one moment to Horacio Arruda for the Global Network of Health in All Policy. And we also work with healthy cities, Region for Health, and all these kind of networks that are actually acting upon the social, commercial, and environmental determinant of health. So this is who we are. We're really happy to partner with you, Horacio, and maybe I'll give you the floor before we see the result of the quiz, because many people are still joining.
Okay,
So,
thank you.
Horacio, yeah, I want you to introduce yourself, but you
Yes,
can do it yourself.
thank you, Charlotte, and I'm very happy to be in connection with all of you across Europe. It's wonderful. That's one part of the technology that I love is to make us being in a network, being able from a different countries to get together. But I'm director and members of the European Public Health Association, colleagues from the Global Network for Health in All Policies. Ladies and gentlemen, my name is Horacio Arruda. I am an Assistant Deputy Minister in the Quebec Ministry of Health and Social Services. I'm delighted to be with you today as a chair of the Global Network for Health in All Policies. The mission of the Global Network is to work with various stakeholders within the Health in All Policies approach by addressing the determinants of health in order to support the implementation of UNESCO Sustainable Development Goals and universal health coverage. The network was launched by the government of Sudan, Finland, and Thailand, the state of South Australia, and the province of Quebec in Canada during the 70th World Health Assembly in May 2017. As of today, the network consists of 31 members, including 14 countries, 9 public health and governmental representatives, 5 academic research institutions, and 3 United Nations agencies. The interest for the HiAP approach is growing because we know that beyond genetics, the living conditions can explain how people maintain or improve their health. These living conditions, as referred as the social determinants of health, it is really about where we are born, the environmental context, both physical and social, income, living conditions, everything we are exposed in our home, school, and workplace, to name a few. In fact, there is a lot of different issues actually in those sectors, and we must work together to try and find a way to do better. Therefore, when working in ministries other than Ministry of Health, whether it's be education, transportation, agriculture, environment, income, or labor, policymakers must have levers to contribute in maintaining the population health. It's a win-win approach of people working in health, but also with other sectors. In Quebec, our government policy for health prevention is a good example of the implementation of the HiAP approach. The policy goal is to improve Quebec health and quality of life and reduce health inequalities. Under the leadership of the Ministry of Health and Social Services, the policy draws upon the contribution of 27 ministries and governmental organizations, their respective network, because those policies must be applied in the field, and the network of stakeholders and more than 100 non-governmental organizations, NGOs, which are crucial in the implementation of these different policies. The policy reinforces the coherence and complementarity between governmental actions about health determinants. It also creates a new synergy between the different sectors involved, allowing for a greater effectiveness and better efficiency. The policy intersectorial action plan has set up more than 100 activities developed in a win-win approach with our partners and are everywhere in the different regions of Quebec and come from, I would say, an approach of bottom-up, but oriented by the orientations of the policy. While remaining with their field of expertise, ministry can develop policies that contribute in maintaining and improving health in the population. Everyone wins. Everyone's become coherent, and we can capitalize in each other's investment in health prevention. Thus, unlike what we say today, with a much pressure healthcare system, prevention ensures fewer chronic disease in the future and therefore a less stressed healthcare system. The reality of the countries may be different from Quebec, but the challenges are similar. Furthermore, common factors can federate countries in an effort to improve health of their population in a sustainable and inclusive way. Therefore, I invite you to discover the Global Network for Health in All Policies through our website to keep being informed of upcoming HiAP resource and activities by signing up to our distribution list and consider the opportunity of joining as a member. Dear colleagues, Let's work together for a healthier population. And thank you for being here. It's wonderful to see that participation of 200 persons around the table. Thank you very much and have a good seminar.
Thank you so much, Horacio. Inspiring as always. And thank you for taking it to the political level. Maybe now, Julian, we have the EUPHA team also here. Julian, would you mind sharing the quiz results to see how we had the results? So, what percentage of health outcome are influenced by factors? 80% is the majority of answer. Yes, 80%. So policy in sectors like urban planning, education, transportation have very, very high impact on public health and more than people expect. So well done. For the second question, oh, it was not the majority of you say 75%. Well, actually, 90% of urban Europeans are exposed to air pollution level above the WHO recommendations. It's WHO recommendations and EU recommendations are not the same. So that is a trick. EU is slightly raising them to reach up to WHO expectation, but we're not there. So 90% of us, I'm a European urban person, are exposed to air pollution. We need health in all policy. And yes, you're right. Finland was the first country to actually pioneer the health in all policy approach during its EU presidency in 2006. That's why we have lots of Finland when it comes to health in all policies. That's also why we seized the moment of going to Finland for European Public Health Conference to develop health in all policy network in Europe. Then policies in agriculture can significantly influence obesity rates. Yes, it's true. It's absolutely true. It's one of the key subject we need to work on together with the commercial determinants of health, because subsiding unhealthy food like sugar, processed grain contributes to dietary imbalances, and this is a big thing. And now, yes, you're not all from the European Union, but we wanted to take you there because it's where we are. And under the Article 168 of the treaty, so that you know everything of functioning of the EU, the EU role is really low actually on the health. It's support, coordinate, and supplement. But we don't have really power. We have lots of advocacy power, but many discussions are happening in the Europe to see if we need to change the treaty to put more health. And I don't have access to the answer for the last one, but many of you answered the last one. Maybe so. To tell you that the new commissioner is Olivier Varelli, and he will be commissioner for health and animal welfare portfolio, and is from Hungary. Now, you will have time for questions. Now it was just a quiz, but before we start with question in the chat and in person, I would like to give the floor to Nicole Valentine. She was the one that opened my eyes to health in all policy in 2015. You're program manager and technical officer in the World Health Organization in Geneva, and you're going to present to us the 4-pillar model, and then we'll have a question moment.
Thank you, Charlotte. Can everyone see my screen? Is it full?
Now, yes, it's perfect.
Yeah. Okay, good. Okay, so thank you very much, Charlotte. Thank you, all of you who've joined online. Thank you, colleagues who I've worked with for many years and know well from the Global Network. I'm really delighted to be able to present to you the Health in All Policies 4 Pillars model that we've all worked on together, and which WHO published last year. I start off with just a recap always of the social determinants of health, or at least the causes of health, because you might find someone in your governments or in your network saying, well, why do we have to work intersectorally for health? Well, that question can be answered with another question, which is really what is holding people back from good health? Is it purely the lack of healthcare? Is it purely up to them in terms of how they behave? Well, obviously, I think everyone who's attending this this webinar, most of you answered that determinants of health have a very important role to play beyond healthcare determinants, but really the social circumstances, the environmental exposures, the socioeconomic conditions in which people are living. On our slide here, we say 45 to 50%. I think Charlotte had 80%, but yeah, depending on the different studies, it is significant. And we put an umbrella around this term in global public policy, which we call the social determinants of health. It's really just to explain this phenomenon that the conditions in which people are born, grow, work, live, and age have a huge impact on their health. And also to then reflect on the fact that, in fact, what creates the conditions in which people are born, grow, work, and live and age? Well, many, many different public policies, the way we organize in society, our governance institutions, these are very, very important. And that's really, in simple terms, the social determinants of health and health equity model, where many different studies and evidence can be attributed. When it comes to the health in all policies approach, WHO, together with the organizations, the organizational committee for the Finland conference and the committee that produced with the participants the Helsinki Statement, developed this definition, and this is the official WHO definition since 2013. The approach is really about addressing these public policies across sectors systematically, and to make sure that they systematically take into account the health implications of their decisions. Support synergies is very important. There's not enough seeking of synergies and win-win and co-benefits, but also very importantly to avoid the harmful health impacts, which we see with air pollution and the way that the air systems are treated as sewers. It's not really considered in any respect in terms of environmental or population health impact. So the approach of health in all policies is really about these three dimensions. And it is an approach that's designed to improve the accountability of policymakers for their impacts on health. And you will note I refer often to health and environment together, because these are areas which do not have a lot of protection in our political and socioeconomic systems and in our policies. So the environment is not very well protected and people's health is not very well protected. And both are, of course, very strongly related. So trying to introduce better accountability in public policy processes for these two dimensions is extremely important. It's also important that there should be a recognition that these policies not only influence the determinants, but also the health systems. How efficacious can health systems be in contexts where the social and public policies are really against health? We have a lot of the cartoons where you see the health system really not being able to keep up with the damage that's being caused. A lot of the medical treatments then also have to be very expensive instead of avoiding the damage to start off with. So that's really what it means to use a health in all policy approach, building on the definition of WHO. As I mentioned earlier, the WHO published last year in 2023 this guidance document, and it really brings together years of observation, discussion with teams, with practitioners, with policymakers in government. What really makes it work in practice? What do you need to do? What do you need not to do? And so this guidance is trying to formulate around 4 pillars, which I'll go through in a short way, how someone who's sitting in government and trying to advance this process can think about the environment they're in and make the institution better able to support them in their health and all policies work. So I'm going to take you very briefly through the guidance document. It starts off with a discussion of the rationale, which I've already covered in some of these introductory slides, but making a very conscious effort to point out that problems are increasingly interconnected. and therefore you need interconnected solutions. And I suppose the common examples that we're using nowadays relate a lot to the COVID pandemic, but also to climate change, or also to migration. These are complex problems that can't be solved by a single sector or a single discipline. So they require multidisciplinary and multi-sectoral responses. And then a second point that's made around the rationale is that while we're not saying siloed, technocratic, bureaucratic systems are bad, they're essential. It's about building the bridges. And as I referred to earlier, the co-benefits is a very important entry point for building relationships across sectors, but it's not going to develop naturally. It needs express and conscious effort to develop the relationships between sectors, and to have a conscious investment in that and the mechanisms for intersectoral work. And then finally, in terms of the links to the social determinants of health equity, we make the point that inequalities are becoming more visible and are becoming an indicator of good governance. So in societies where people are seeing greater inequalities, governments are being held account to change, sometimes perhaps with a solution that might not seem to be the most efficacious one. But nonetheless, the inequalities in COVID became very clear, that there were the death rates were much higher for people living in disadvantaged conditions. With climate change, it's also who's affected by the massive events more. Often people who've built houses in areas of floodplains and areas where land has been cheaper. And then also just the general wealth inequalities. I think in the last decade, we've had a number of very high profile publications that have emerged looking at the changes in wealth and income distribution across populations in all countries. So with that, the point is made that inequalities themselves are also complex. How do we end up with diverging positions and conditions that people are living in terms of access to education, access to good jobs, access to retirement and things like that? How's it, what is generating these inequalities in society? It is complex. So we put forward in the guidance document the use of the health in all policies approach, really to address these inequities. The four pillars are shown in this graphic, and I'll start off by pointing out that around the top we have what we call the arches, and at the bottom we have the foundations. In the middle we have the pillars, which are actually more in triangular shape. The first outer layer of the arch refers to what I've summarized before, and Charlotte's mentioned the social, political, environmental, cultural, commercial, and economic forces. So sort of giving visibility to how different sectors would describe the different domains that they work in. But we in the health sector, in terms of the way we've organized our evidence, we bring this together in the form of the structural determinants of health equity, or the social determinants of health equity. We use some of those two terms interchangeably. So that's really how we've organized a lot of the evidence in this sphere. So in that context, then we propose the four pillars of health in all policies, which include governance and accountability, leadership at all levels, ways of working for health in all policies action, and resources, financing, and capabilities. And in the center, you'll see there's a strong connection between governance and leadership, really around a whole of government plan and activities for policy action. Having such a plan is quite fundamental for at least expanding health in all policies into diverse sectors. And then also such a whole of government plans are really fundamental for shared policy projects and proposals. So these form both important elements of governance and accountability, as well as for leadership at all levels. At the bottom, we have the foundations of health in all policies. So when people are working on health in all policies, having a look around to see the culture of collaboration that's within their government, also gives one an idea of the extent to which one can use a particular strategy, or what is expected, or what can be feasible. And so a government that doesn't encourage a lot of collaboration is a harder environment within which to work. And so, but a government which has opportunities for collaboration can then be quite a good resource for identifying which sectors to relate to, depending on where the collaboration is already encouraged. Another foundation for the type of the health and all policies approach that will develop in a particular setting relates to the principles that government has with respect to bridging gaps between the different sectoral portfolios. What is often done, or could, as a principle, could be it could be a parliamentary committee on a particular topic that straddles a number of sectors. So this could be the way that government deals with bridging gaps between sectoral portfolios. So this needs to be taken into consideration when forming the health and all policy strategy. Finally, the government's values with respect to delivery of public policies and services with equity is also very important. If equity is not commonly understood in another sector as being an important part of their policy mandate, it then informs how to approach that other sector, or it also requires then sensitization. So going to each of the pillars, which are the next few slides, and then I'll go on to evaluation and then roles. So the first pillar is really around governance accountability. And what's important to point out is that in this area, the governance and accountability is really supported by having an authorization environment and mandate. You'll see examples in the guidance document. It might be a memorandum of understanding between two sectors, for example. Another important subcomponent in this area, and something I just forgot to mention when I showed the slide which showed all the pillars on, was that in the guidance we don't say you have to do first governance and accountability, then leadership at all levels, then ways of working. What the case studies that on which we build the guidance do seem to indicate is that you need to have all of the elements, but not necessarily all of the sub-elements, but at least one element from each of the main pillars. So you don't have to have all these elements that I'm listing on this slide for governance and accountability. That's what we found from the case studies. And then again, as I mentioned, you don't need to have a particular sequence, but when you have all these pillars in place, you can pretty much say you're up and running. Okay, sorry for that interruption, but just to continue now. The second bullet relates to the component of having layered cross-government committees, which also are informed by existing structures and mechanisms. The important word there is the layering, because in case studies where there wasn't layering between the political and technical levels, you would often find a blockage. You would have a political interministerial committee, but then no technical collaboration. So that didn't work. Also, layering is important with respect to the different levels of government. If you're only having something at the national level, but not then having any engagement in health and all policies at subnational levels, that's also seen as a weaker type of, potentially having weaker results. I introduced the whole of government plan and the support for joint projects and policy proposals as quite fundamental when I showed the overall slide. The whole of government plan linked to SDGs or climate or a development vision with related indicators that you could pin to social determinants of health, equity, and well-being is a very good entry point, because if the whole of government plan requires other sectors to be accountable for an indicator that relates to some very strong determinants, it becomes a good entry point for discussion and a forum for discussion around collaboration. This is a diagram which really looks to how the central government, individual agencies, and cross-agency collaboration would play a role in terms of intersectoral work, with ministerial committees providing the political authorizing environment. You'd also have ministry heads supporting the work. You would have cross-government executive oversight, which is more at the bureaucracy and planning level. And then you need the technical groups as well. So having these different mechanisms involved in intersectoral work, it's important to think about the different roles of these different mechanisms. For leadership at all levels, part of the emphasis here is on the role of champions. It's recognizing that hierarchies are necessary in bureaucracies, but then being able to find a way that with each person in their sphere of influence could be a champion for better collaboration and multi-sectoral approaches. Leaders who really advocating for health and all policies can eventually change the culture, so can influence the foundation of government. If you have champions for collaboration from different sectors, it can change then the environment within which health and all policies approaches can flourish more. Networks of champions around practice is also very important. We've seen in the case studies. And then being able to work with these networks to build capacity to work intersectorally, which also links to the last pillar, is very important. In the third pillar of ways of working, this area really focuses on the attitudes, mindsets, behaviors, and practices that the team that would be, you could say, the initiating team or the team working in the health sector is really trying to work in a positive way with other sectors. And fundamental around this is the element of collaboration, the element of co-design. And in the graphic on the right-hand side, you'll see this goes from the complex policy issue, which requires multiple disciplines and sectors for the solution, committing to collaboration, co-defining the issue, co-designing the process, co-creating solutions, and then co-delivering actions. In this process, the building of trust is really, really important. So in the ways of working, if there's one word to remember, or two words, it's probably collaboration and trust. But trust is perhaps the most important. In the ways of working, you would also be using data and evidence and knowledge from the other sectors, and other sectors have different ways of knowing, different ways of communicating, different ways of understanding causation. And then fundamentally with the communities affected, and community engagement is also an important principle in the ways of working. Finally, the resources, financing, and capabilities pillar is really important because a lot of the people who've reported on their experiences say that they were often expected to carry on doing collaboration without any time commitment, human resource commitment, any financing, and this can't really work. Dedicated human resource roles are extremely important. Emphasis on the role there. Sometimes people have said 2 to 3 full-time equivalents are needed, but the role of collaboration is important because that's really what's going to sustain the relationships between the sectors and the ability to identify how to better coordinate the resources of different sectors to bring to bear on the solution. Obviously, some budget for the health and all policies function should be created, with the emphasis on the functioning area, because the function could actually spread between health and another sector. The functioning units could be comprised of more than one sector to support the collaboration and the advocacy for collaboration. And then in terms of the point of budget, a lot of people say, well, they're scared to lose budget. It's not about that. In terms of budgets, it's about being able to improve coordination on a common impact theory that's grounded in the evidence of the whole framing of the social determinants. So coming to the end now, if we define success, there are different ways that success is defined, and we go in the guidance itself, we look at different ways of evaluation. But without going into detail into a specific evaluation, I just wanted to point out 3 elements of defining success. The first way success can be defined is how successful is the collaboration mechanism itself? How successful is the intersectoral work? Does the process of the collaboration meet the expectations of the agencies and actors involved? And we have in the guidance document a number of questions around inputs that could be asked to judge effectiveness of collaboration mechanisms. Second area is the policy process. Is there, as a result of the Health in All Policies approach, has the actually process for public policy decision making, because remember the definition, it's about integrating systematically into considerations in the public policy processes. Have we seen a result and a change in the processes and institutions themselves in terms of how they're considering equity and health? And finally, the policy impacts, which could be looked at in terms of, have goals of the other agencies changed, or the way they measure their goals changed? And then finally, if we have a social determinants dashboard, can we see across the different social determinants, disaggregated by socioeconomic status or ethnicity, have we seen a positive change? Do we track positive changes over time? And ultimately, are health inequalities decreasing, and is health equity improving?
Thank you very much.
Finally, sorry, last 2 slides, I'm probably taking a bit too long. We've got the role of central government and the role of health authorities. Just to say, coming back to the role of central government, you really need a support from the central government, and that is 3 elements of the support that you need. And for health authorities, you really need an inquisitive mind, a health authority that's willing to understand the priorities of other sectors, and to build, to engage in dialogue, and to build and generate evidence that's relevant for the other sectors to understand their impacts and the responses. So that's all I wanted to share, and thank you for giving me the time, and sorry if I took a bit longer than I should have. Thank you.
Thank you very much, Nicole. It's really hard to cut you because that's so interesting, and that reflecting on the last pillar. I mean, there's love, and all saying we want health in all, health for all policy, and there's proof of love that you give budget and resources to that. Yes, the slides are shared, posted, and I think on the Global Network for Health in All Policy website, along with a very, very good resource that we'll share at the end, which is a fact sheet on how to use that with questions. So everything that Nicole has said, we want to show you how to implement. We'll talk about data with Timo, we'll talk about implementation in Slovenia with Peter, but right now I'd like to give the floor to Julian Fisher, Director of Zero Water Day Partnership. You're also a trainer of trainees for Health in All Policy, and in amongst other places in Charité. Do you have questions on the chat?
We haven't got any questions as yet, but we've got an interesting comment about Scott Gear's Lancet article in 2022 saying that it's very important to have this bi-directional relationship. And I think Nicole and yourself, you mentioned that it isn't a one-way street. It's very much not just working bi-directionally, but multi-directionally, because obviously no problem is between 2 parties, and obviously multi-sectorally. So that was one of the things that came through, and I think links into what you've been saying.
Yeah, I think it's also important because it stresses the bi-directional, stresses also the asks that the other sector has of the health sector, and that's very important.
I don't know if you touched on it, Nicole, you know, the Sustainable Development Agenda. I mean, obviously, again, whole of government, whole of society, that really links into that. So I don't know if you wanted to say a few words about that linkage to the SDGs and that agenda.
Well, for me, I drew the emphasis on the linkage through the whole of government plans, because a lot of the whole of government plans are linking to the SDGs and the reporting of the SDGs. These are whole of government activities which cut across many sectors. So I think that's important. And of course, if you look at the social determinants monitoring framework that was released earlier this year, you'll see many of the SDGs are reflected as good indicators from which to gauge improvements or deteriorations in the social determinants of health. Thanks.
Yeah, and Gillian, we have a question: how to convince policymakers to be on board with health in all policies? So I know at EUPHA we're trying to create a political advisory board, but maybe Horacio or Nicole, you'd like to say something about that.
In fact, I think actually that the opportunity is there because all healthcare systems are under a big pressure, and we cannot sustain this approach if we don't introduce prevention. But it's clear you need to have your own minister and if possible, even the prime minister aware of those issues and we wanting more coherence. And I think it's a work that takes time. It doesn't happen in the first day. It needs to build that win-win approach, build that trust in between people, and build the advantage and see that we are not asking other ministries to do our work on health because we already had a lot of the budget in the healthcare system compared to education and others. But we are trying to emphasize their own strategies and politics and try to be the cement between all those because, you know, there is no only health in all policies approach. There is their own sectorial strategies, action plan, their own vision of the different ministries. But it's work, the higher you want, and if you can have access to the prime minister or the cabinet around the prime minister, and if you have 3, 4, I would say, champions in their own sectorial policy, bringing together those people, having a common vision, understanding the same words, because the concept of determinants of health is not always understood by everybody. So there is a lot of exchanging, I would say, building trust and see really the approach of win-win is very important. You don't arrive with your public health program design. We are creating. What is the problem? Where are the problems that we can go together and make it better? And even with a little money, more money, you can emphasize and capitalize, and I would say add coherence and find solutions to something that in silos doesn't find solutions.
Yes, Horacio, I've just popped in the chat again, just picking up on that first point you made, being very aware that now other ministries are having to look at health and have their own lenses and ideas. So again, just understanding that we're in a sort of a melting pot together, and health may be addressed by other government agencies and ministries. So
yes, and when we work with the municipal regions, we talk not about health, we talk about quality of life. But when you talk about quality of life, it's meaning that you will work on green spaces, you will work on a better housing, you will work on better security, you will work on higher, I would say, mobile transportation. So, and actually, there is a convergence of those needs in different sectors. And it was not the case 15 years ago, I can tell you. It's different. Our transportation people actually seeing the impacts of climate change, even if we are not the champions like Finland. I know that we should all live in Finland because they are the happiest people in the world, supposed to be in some situation, but I don't know if they will accept my immigration to Finland. But in fact, there is this new crisis of healthcare and climate change that are making people think we cannot continue the same way.
Yeah, and I think as you're saying, I put in the chat as well, these windows of opportunity. And I do think climate change is a window of opportunity for health and all policies. And Bert, your point about the empathetic interests, again, as Horacio was saying, it's about finding quality, common language. So talking about quality of life, that means that a lot of people can engage and understand very quickly. So as you're saying, being empathetic, but also understanding the words we use will either engage people or set up some barriers.
Yes, exactly.
Charlotte, I don't know if you wanted to come back on the comment about case studies from cities, because I know that's where you come from.
Yeah, well, I can give a first answer, and then we'll leave the floor to Timo. I've been, for those who don't know, I've been Deputy Mayor for Health and head of Healthy City, and that's how I discovered health in all policy. And what I know is convincing is mostly being a champion or cheerleader and getting to be invited in all meetings from agriculture, urban planning, and everything, and making the case for them, not for me. And often it takes lots of humility to defend health in all policy, because you need the other to win from it. And that's always very interesting. And to connect with the question of Alistair Leyland, assessing the success of HiAP approach, emphasizes the importance of monitoring. In our case, in cities, we really try to have scientific people inside the city and do implementation science. So not send something and evaluate in 5 years, but be a lot more agile, which is something that was really useful. And same for the money that Bert, you're asking. And we were trying to put the money together to finance the implementation science. And I think for all that, I was really, really inspired by the work of Timo Stahl in Finland. And you're from the THL, National Institute of Public Health. And I've been asking you over the past 10 years about everything you're doing in Finland, especially for monitoring, and proves the case not only to health, because we are convinced, and not to be an echo chamber, but convince the other, we need data and we need monitoring.
Thank you, Charlotte, and good afternoon to everyone. I guess you can hear me well. I will share my screen. Hopefully it will work out. Yep. And then let's see if you can see my presentation on whole screen mode. Just a minute. Okay, now, is it okay?
Not yet. You might, oh yes, now it's good.
It's good. Okay, yes, so good afternoon to everyone. I will just give you a quick snapshot what we have done in implementing health in all policies, and especially how we have monitored that one. I know that you can do the monitoring and evaluation of the success of health in all policy in many ways, but this is what we have now done in Finland for years already. And just to give you a brief overview of that. But before that, just a few words about the health in all policy in Finland, because the key elements, I think it's unique because the key elements of health in all policies, they are actually in the legislation. I will show that. And then about our benchmarking system, which we are using for monitoring the implementation of health in all policies on local level. And then just a few words about the lessons learned. This is the legal framework for health in all policies in Finland. I have to say it's quite strong, although already the constitution has the key elements for people's health and well-being. And then we have a local government act, which also strengthens this perspective. But especially we have the Act on Organizing Healthcare and Social Welfare Services. And there we have the specific obligations task for local and regional authorities. We just have had huge health and social service reform. And we have now specific tasks that are all much the same for the municipalities and also the well-being services counties. that are responsible for organizing the health and social services nowadays. Before the reform, it was the municipalities who were also responsible for organizing the health and social services, but nowadays it's on the regional level. These tasks and obligations that I now show are common, the same one for the municipalities and the regional authorities. They have the same obligations. When it comes to objectives and measures, so in the strategic planning, the municipalities and regional authorities need to set the objectives for the promotion of health and well-being. And they need to set also the measures how to achieve these strategic objectives. So they need to put that on the paper. And they also need to nominate, indicate a body that is responsible for the promotion of health and well-being of the inhabitants. So they need to nominate that one. And then that's important that we know which body is responsible for that. And there's also obligation for cooperation between the administrative sectors, but also with the other local actors, private enterprises, and NGOs. And all these are set in the law. But that was not all yet. There's a kind of request for impact assessment. So it is said that the impact of the decisions to the health and well-being of the inhabitants must be considered. The Act does not say that they should use a specific impact assessment tool, but that's the practical application, of course, this decree. About the monitoring reporting, they need to produce yearly a short report and once in 4 years a comprehensive report on status of the health and well-being by population groups, and also factors influencing the health and well-being and measures conducted. And these reports need to be given to council, whether you are in the municipality or in the well-being services counties. And there's also obligation for the municipalities and the well-being service counties to work with each other and support each other in their work. I took this checklist from the 4-pillar document, and you can see here that I have highlighted or left to see those elements that we are able to monitor in our system, and are highlighting the different elements of healthy policies. We have some indicators for the governance and healthy workforce and processes and outputs and outcomes and impact at policy level. And I think if you're implementing or considering how you are doing in your country or in your city, so you can take this checklist and see whether you have these kind of elements in place. These are more like a structural elements and that are needed, that you are able to do systematic and sustained cross-sectoral work, so to implement healthy policies in principle. So many times people have asked me, has the implementation of healthy policy been successful in Finland? And is it really possible to collect data indicating the success of local level implementation? And for that purposes, we have a benchmarking system that we have originally developed for another purpose, but we are using this benchmarking service, benchmarking the project and the indicators from there, because the key is to measure and assess the health promotion capacity and activity of an organization in a comparable way across sectors of the local government. So these we are using for as a database for monitoring the health policies implementation. It's very applicable for monitoring health policies because we have a generic framework and then generic framework that is measuring the commitment to health promotion, how health promotion is managed within the sector that is observed. Are they monitoring the health issues? What are resources they have health promotion, and do they have common working practices? And also, what kind of possibilities the public has to participate in the planning and evaluation of the activities, for example, in the municipality. Here you can already see that we have the data from different sectors of the municipality. And as you can see, we started here. We started with the primary healthcare in 2008, and we have collected this information directly from the municipalities. And these are the sectors that we are, where we are collecting the information every second year: from primary healthcare, physical activity, municipal management, basic education, upper secondary education, vocational education, and culture. And you can see that the response rates or the coverage is extremely good. So it means that also those the municipalities and well-being service counties, they see our system useful for them to develop their own activities and evaluate their own work. So this is an online system that everyone can access. So just now a few examples of that checklist how we have assessed that. For example, we are asking, does the municipality have a working group for health promotion? And this working group is intersectoral working group. Well, you can see here whether they have it in no working group at all, or cross-sector, or the extended municipal management group, which of course is better than the cross-sectoral working group, or if they have regional welfare team. And that's almost in every municipality in Finland. So green is yes, red is no. And then what about the coordination and the workforce? So we are asking how large contribution does the welfare coordinator, planning officer, or similar have in welfare and health promotion in your municipality? And whether there's one coordinator or if there's a bigger city in question, they have more than one coordinator. And based on this, again, we have our benchmarking here: high result and average and low result. And you see that there are some municipalities who still don't have any resources for this cross-sectoral coordination work. And then whether they have this management group, and the management group is monitoring the health inequalities in the municipality. And we see that many municipalities still don't monitor the development and the status of health inequalities within the inhabitants. To smaller municipalities, it's a question of data. They don't have the data, but some other cases, it is the question that the data is not provided to the management group, so they don't have an idea of that. And I guess that was the last one. Yes. So lessons learned. It is possible to collect comparable data indicating how well the key elements of health levels have been implemented. So this means that we have those elements that makes the cross-sectoral work systematic and sustained and possible, but it doesn't say what's the quality of the work that they are doing. Are they doing good work? We don't know that from this data. But we know that publishing this information online serves the local decision makers in assessment and planning. It makes the municipal actions transparent to also the inhabitants. And of course, we are using the information a lot on national policy making. And also the data is used to a great extent to assess of the law enforcement. So the laws that have been stipulated, are they actually put in the effect? And the last one, the monitoring and progress and publishing the result in online benchmarking system facilitates health in all policy implementation. And because it's a benchmarking system, so peer learning and pressure from the neighbor cities, that's also very effective. We have seen that. And then there's some further reading and sources which you can take a look later on. Thank you.
Thank you very much, Timo. And again, we've been talking in, well, 9 years now, how we could develop that in European level and share what you've been doing to other countries. And because, yes, as you said, benchmarking, and I've been seeing that other are doing something motivates other, and we could leverage on that. Let's dream together. I would like, before we go to the questions, you can have questions on the chat, but Peter, you have a presentation. Peter, you are from Slovenia. You've been doing lots of things, and you have 10, 12, 15 minutes max to tell us as how the Center for Health and Development in Murska Sobota is, as your director of it, is doing successful health in all policy practice. I hope our colleagues from Ukraine are still here, because you're also showing how it's important on the relationship with EU. And I think this is really fascinating on a political point of view, and all the co-benefits that are even larger than we would thought. The floor is yours.
Thank you, Charlotte. Thank you for inviting me to present our experience with health in all policies approach in Slovenia. This was one particular case that was happening in my region. It's called Pomurje region. I will explain you where this lies and everything. I know I have a bit long presentation. I will try to run through it and keep to the more important things, but I think you said it will be shared later on with on the website. So if I can ask you maybe to put the presentation on, and let us move to the next slide. I will start with some basic information on Slovenian health system, touch a bit upon historic development, which is also important for understanding of the context in which this health in all policy approach through our program MURA was needed in our region, and conclude with some more recent developments that embedded some of the takeaways from the pilot action in terms of local health in all policies approach through multi-sectoral collaboration into the health system itself. Next slide, please. Slovenia lies in Central Europe. You can see it's between Italy, Austria, Hungary, and Croatia. It's small but very diverse. We have mountainous, alpine region, small Adriatic Sea coast, hilly vineyard, and we are stretching towards Pannonic Plains in the east, where our region Pomurje, with our regional capital Murska Sobota, lies. Slovenia has a little more than 2 million inhabitants and is member of EU since 2004. Next slide, please. So the foundations for Slovenian healthcare were laid already in the 19th century, but underwent a groundbreaking evolution in 1920s, and then Kingdom of Serbs, Croats, and Slovenes, with the introduction of the principles of social medicine by Dr. Andrija Štampar. Already then, these principles acknowledge the fact that without improving general living conditions, social circumstances, and health literacy, there will be no progress in population health. This, for that era, quite revolutionary approach materialized through establishment of first healthcare centers in communities in Slovenia already in 1926. And after the Second World War, Yugoslavia became a socialist republic and also aimed to provide free healthcare to everyone. And during this period, Slovenia also saw significant improvements in the healthcare sector, and hospital clinics and primary healthcare centers were built across the country, including in the rural areas. Next slide, please. As an independent state after 1991, Slovenia then transitioned from a socialist economy to a market economy, and the healthcare reform became a key issue, although the concept of the healthcare still remains socio-medical. This means, in consequence, that the access to healthcare in Slovenia is generally universal and comprehensive. We are trying to ensure that all citizens and residents have access to necessary medical services. On the slide, you can see the public healthcare institutions network across the country. This is now consisting of 63 primary healthcare centers, 10 general hospitals, and 11 specialized hospitals nationwide, with the support of National Institute of Public Health and its regional units. In our region, we have 4 primary healthcare centers, 1 general hospital, and a regional unit of National Institute of Public Health to cover the health needs for about 120,000 people. Next slide, please. So, with the health system relatively good, based on social medicine principles, accessible to almost all, and geographically evenly dispersed, the question emerged: why do we then still have such persistent health inequities between regions and between different populations within regions? The then available data clearly show a connection between limited regional development and poor health of population. You can observe on the slide almost perfect geographical overlapping of higher mortality rates with lower income and employment. Now, considering all the facts and evidence, something needed to be done, and this led to the first activities towards the inception of cross-sectoral investment in health program that was named Program Mura, named after the river that is flowing through a region. Next slide, please. There were several critical factors, like the WHO investment for health appraisal undertaken at the request of the Ministry of Health of Slovenia, and also the accession negotiations to the European Union, among others. They served to create more receptivity to addressing the problem as a part of the regional development agenda, since this was largely related to the criteria for EU accession. And this emphasized balanced regional development. This then created actually the opportunity to link these issues, the regional development and health inequities at the regional level. So to strengthen interest and form alliances with other sectors, it was critical that the key messages from health sector were both, they had to be evidence-based and also, and this is very important, they had to be tailored to the different audiences for which they were intended. Equally significant for success at this stage was to enlist the key stakeholders that had access to important decision-making processes across the different sectors of government and society, which we heard before from Nicole. It was this layered approach. Former and also especially informal mechanisms and networks also played an important role. So when we look back at it, this was clearly an health in all policies approach, and the way in which the issue of equity was presented actually ensured that it resonated well with the agendas of other sectors, and it involved all levels of governments from national to local authorities. One important tool used to win the support of all sectors on all government level was a policy scanning exercise, which was done then by the Ministry of Health of Slovenia. It involved examining the policies of different government sectors and the plans of other regional stakeholders with the aim to identify common goals and interests relating to health and the development, to see if there are potential areas for collaboration, but also the existence of competing interests that could block or undermine the health in all policies approach. So the most receptive non-health sectors identified in our case were the tourism, agriculture, and food industries, and the most acceptable health issues that would be prioritized for the implementation of the program Mura were healthy diet and physical activity. So this cross-sectoral policy scanning was really helpful in identifying common priorities and enabling a dialogue and also on feasible entry points for developing common policy to tackle the social determinants of health. Next slide, please. So all this led to the adoption of first multi-sectoral investment in health program in Slovenia. It was approved by the government and became a development priority in our regional development program. So this had also very concrete consequences in terms of resources. So there were finances. The financing of regional development program in this period came actually from the Ministry of Health Fund for tackling health inequalities, as well as the regional investments from other ministries and EU funds, which were also used to improve health and well-being in our region. Next slide, please. You can find more about the mechanisms and ways of working in the publication program Mura. I put it in the references. I have not much time to explain this more, but you can see a taste of what was going on in the field. There were several projects to improve the determinants of health, mainly in the tourism, agriculture, and education sector, but also in health promotion and also critical investment in water supply system and nature protection at that time. Next slide. And now we come to the structure and the layered coordination mechanisms. So this intersectoral collaboration was supported by the coordination mechanism at national and regional levels. We had on the national level intersectoral governmental project group for health and sustainable development in Pomoria. And on the regional level, we had regional program council that was established in parallel with the national project group. And it was consisting of regional stakeholders and a coordinator, which was then our institution. We had 4 working groups focused on the 4 pillars of the program and its foundation, and which was healthy environment. Not to be forgotten, all staff involved in program Mura was also trained in the investment for health and health in all policies approach, as well as in monitoring and evaluation, policy development, and health promotion. This has strengthened intersectoral communication, negotiations, and project management skills in the region. Next slide. Yeah. The key knowledge takeaways from Mura experience in conducting health in all policies are now in these bullet points. I will not count them down, but it was also mentioned before. Let's scan for existing structures rather than create new ones, so we can save resources, and it's also not perceived as a competition to the old structures. Facilitate shared ownerships of projects, because otherwise we might lose the support of other sectors or key stakeholders, even if the results would benefit them. Used an agreed common language, I mentioned that before. Ensure backing at the political and civil society levels. This could be, of course, either most difficult or the most easy task. It depends on the current political direction. But international organizations such as WHO, UN, EUPHA, and others can be very helpful in this regard by promoting health and well-being as universal right and civilizational priority, as it was in the case of Program Mura. Okay, I also want to stress again to use also informal communication channels, not only the formal, because informal is usually better than formal. That's our experience. Maybe in other countries you have other. So the last thing I want to talk to you about, next slide please, is how it is today. Well, primary healthcare in Slovenia is co-managed by municipalities, and this implies that they are all involved in addressing the health challenges of their community in one way or another. So for support in making their decision evidence-based, our National Institute of Public Health established a web-based system where municipalities can observe certain health indicators of their population, which are updated annually, so that Finland has this even more elaborated. I'm not sure if we didn't copy a little bit from the northern countries in this regard. Another feature of primary healthcare system in Slovenia is also our community nursing, and it's a bond between health system and individuals and their families, but also social and other local services. And now we come to the more recent developments. This is the new paradigm that we call it the community approach to health. And this can be described as an approach where the local community itself plays a central role through coordinated actions by its members, both individuals and groups aimed at improving the health of all members and their environment. We had a national program on that. It was called Together for Health, and its aim was to establish local groups for health promotion and reduction of health inequalities in local communities, with aim to discuss local health issues and shape the health system to their needs as far as this is legally possible. And this is the first systemic application of health in all policies that I know of, based on the results and insights of our pilot program, URA. Parallel to this, the government invested massively in establishing health and mental health promoting centers within primary healthcare centers nationwide. And this should then provide community with tailored health promotion services on local level according to their needs, of course. Although the program is now facing some challenges from underuse of the services to accessibility for those in more remote rural areas, the program is gaining momentum and has evolved from pilot in 3 municipalities to a national program that has a goal to provide these services in every primary healthcare center in the country. It is, on the other hand, much harder though to monitor the implementation of the health in all policies through local groups for health promotion, because it is voluntary and also it differs from one municipality to another. And it's mainly also determined by the interest of the mayor in community approach and to health and health in general. And this is why we also find this health in municipalities website not only very good monitor of health of population, but also good motivational tool to motivate the decision makers towards investment in improvement of health of their constituencies. And this is all from me for now, and I'm open for questions. And this is where you can find the material to look deeper into the case.
Thank you very much. Many material, a lot of inspiration for different ways of addressing that. Julian, do we have questions that we have 2 minutes to address before going for the next steps and keeping the hour?
Yeah, sure. There was a question from Heidi to Timo, but if you look in the chat, Timo's answered that question. As far as I could see, there weren't any other questions coming from the chat. So I'll hand back to you.
Okay, no, yes, we want to know how it works. We want to see how, from seizing an opportunity and learning from champions, we actually make different cases, because as Nicole said, you just need to adapt it, and there's no something that you can duplicate. Indicators maybe, but not governance. And we have in Europe and in the world actually a collaborating center in Tampere. Lauri Kokinen, you're the coordinator, head, I don't remember the real title, but over to you.
Thank you, Charlotte, and thank you for all the presenters and the audience for this lively webinar. So at this point, I think it's good to take a quick look to the future, and meaning that the next and 18th European Public Health Conference will take place in Helsinki in Finland from November 11 to November 14 in 2025, so in less than a year from now. And the main theme for the next European Public Health Conference will be, or the title of the conference will be, Investing in Sustainable Health and Well-being. And I'm quite sure that this conference will offer great opportunities for all of us for learning about health in all policies, research and practice, and also opportunities for us to network with all the HiAP experts. And the abstract submission will already be opened in 2 months on 1st of February for both sessions and for individual presentations. And during the conference, there will be also this kind of official social program that will include welcome reception and conference dinner. And then together with my colleagues at the WHO Collaborating Center at Tampere University in Finland, we are also planning to arrange some kind of more informal get-together for all the people interested in health in all policies approach. So I can almost promise that the weather in Helsinki in November will be grey and cold, but the atmosphere in the conference will certainly be warm and I believe very inspiring. So I just want to would like to see as many of you as possible in Helsinki in 1 year. So put that to your calendars, and the health in all policies will be one of the main themes of the conference. So thank you.
Thank you, Lauri. And to follow on that, as we said, we really want to empower you. So we'll be opening a training. I'm not sure we have some places left for EUPHA members and section, but maybe there still. We are working with Julian Fisher and the Global Network. We have Ukraine and Kyrgyzstan and Kazakhstan who are already really interested in empowering themselves. What we want to do is do the training with them and see what happens and study it and use our resources on evidence and then publish a supplement of the European Journal of Public Health about what is happening here. Health in all, health for all policy. How do we show the case even more? But we don't want just to have the journal, we want it to live. So present in Helsinki, present the journal, do pre-conference, and then follow up. And after Helsinki, it will be Bilbao. You may have seen Manuel Franco in the chat, and it will be about city. So we are on a long run here, and we really want to see how we grow communities and that you can learn from each other. We are very lucky to have very dedicated people in Finland happy to share their experience. And we will be here for you as EUPHA to support and make it know from the scientific perspective, but also connect with WHO because it's something really important that all the time we connect science and the people implementing and the collaborating center and the WHO. So we have the same call, the same wording. And all of you said that something that is really hard is to take the same language, speak the same language, because sometimes public health, we have a very big jargon. So how do we learn from each other and how do we amplify our voices? So that is the new normal. Does anyone want to say a final word? Horacio.
What I'm going to say is that we know to share those experience is a great thing. We can be inspired by the issues of the others and the ways they do it, but you have to create it in your own reality. And I think that's a very important thing. And I just will say that even if sometimes we think things doesn't go as fast as we want it to go, things are getting better. I hope so. There is issues, there is wars, which are terrible. There is poverty, there is refugees, there is climate change, but we must weather that. We must take it to an opportunity to do better with this kind of approach and reduce what is very important, the health inequities. So thanks to be here and hope we're going to be perhaps seeing some of you in Helsinki in 2025. I think it's a wonderful place to be. And don't rent a car, just use transportation and bikes and everything. It's a wonderful place to be, Helsinki.
Charlotte, we've got a question in the chat there. I don't know if you want to pick up that very quickly.
Yes.
How do we work, EUPHA work health in our policy in the EU policy, for example, in the Green Deal? Well, we are doing that. We are starting that with the network. We now have, and she's here too, a policy officer in Brussels. So we have an advocate and we have a champion in Brussels, and she's going to convince MEPs, member of European Parliament, sorry for the jargon, member of European Parliament, one after the other, that health is good for them, at least to be elected and essentially to improve the life of people. Happy to share more about that. But Nicole, would you like to say a closing word too?
I just want to emphasize it's for the long haul. I mean, new generations come and go and politicians change, and we just have to keep on going in this direction. We don't have a choice. We need to, for the population's health and for the environment's health to be considered in everything we do. It needs to be integral to the way we relate to our societies, to each other, and in the places we live. So it's here for the long haul, and it's not a quick fix. It's not a pill that you can take and things will be magically different, but it takes people like us to keep going. So I welcome anyone who wants to take on this and just persevere. That's all I can say. That's all I can do. That's all we're all doing. Thank you.
Thank you. Timo.
Thank you. I think this webinar has been a very good place and to learn and also share experiences. Although this has been snapshots, I think this will be some inspiring for some people, and I hope that someone can just take some message back home and think how we could apply and adapt that in our country. And I really hope that we will see in a year in Helsinki and have more possibilities to talk. And as Nicole also said, the politicians go and come and go, policymakers come and go. That's why we have to build these very strong structures that will make sure that we will have the discussion and continuation of the work, although the people are changing. So we need the dialogue. Without the dialogue, there's no action. Thank you.
Thank you. Peter, how can we connect you with members if they want to learn from you?
I hope I left my email somewhere in the presentation. But otherwise, I think such networks and these new technologies that enable us to speak to people around the world simultaneously are really maybe not used enough. We have one case in Slovenia. You have the whole Finland of cases in your municipalities. I'm sure there's a global repository of good practices in terms of how to put health on the agenda of other sectors, how to put health in the first place in every government, in local and so I urge you to have more such meetings, to share more experiences with each other. I'm very much ready to share my knowledge, my experiences to everybody who will contact me, and I hope that you are also, if I ask you.
And yes, Heidi, we are going to gather all these links and all the thing. Maybe Julian, you want to share how you're training people, because all these links, maybe we cannot read them all, but we need to be accompanied.
Yeah, thanks very much, Charlotte. Just for everyone to know, obviously there's a huge wealth of information, both in terms of the experiences that we've heard today from WHO and Nicole and from Canada and Horacio, but also the links. So we're going to be putting that together in an ebook so that we'll be able to link to all these things together in a very nice curated ebook that will then support some of the courses that Charlotte's been speaking about. Charlotte.
Thank you. And last but not least, I'd like to share this document. I put the link in. And huge congrats to the Global Network team. And in this fact sheet, you've been doing all the way to see how all these concepts are operationalized. And I wanted to finish with this checklist of the 4-pillar model, which I think the work has been amazing, going from science to implementation. We'll be here for you for the next step. Big, huge thanks to Camille and Marianne, who have been doing the work, and Julian and Sarah from EUPHA too. Thank you all and have a great day. We're exactly on time. Thank you for respecting that. And let's connect in Helsinki at the most, but I'm sure well before.